Hi, I'm Michelle Kittleson, Professor of Medicine at the Cedars-Sinai Smith Heart Institute and Associate Editor for JACC, here to talk about sodium zirconium silosilicate for the management of hyperkalemia during spironolactone optimization in patients with heart failure and reduced ejection fraction, with first and corresponding author, Dr. Mikhail Kosiborod. This is being presented in a late-breaking clinical trial session at the AHA on November 18th with simultaneous publication in JACC. So Mikhail is a superstar cardiologist who barely needs any introduction. He's an internationally recognized expert in cardiometabolic disease, has led 1 million important clinical trials. Currently, he is vice president of research at St. Luke's Health System and professor of medicine at the University of Missouri Kansas City School of Medicine. However, congratulations are in order because as of January 2025, he will join AstraZeneca Research and Development as Senior Vice President for Late-Stage Cardiovascular, Renal, and Metabolic Disease. So let's dive into the REALIZE-K trial. We all know how important mineralocorticoid antagonists are for patients with HFrEF. It has a strong class 1 indication in both the AHA/ACC, HFSA, and ESC heart failure guidelines, but we also know that use is hampered by hyperkalemia. This trial randomized patients with MRA-induced hyperkalemia to SZC versus placebo for 6 months. Patients who received SZC were 4 times more likely to achieve normokalemia on spironolactone 25 milligrams a day or higher without rescue therapy. However, more patients had adjudicated heart failure events when taking SZC versus placebo. So my first question to you, Mikhail, tell me about the design of the trial. There was an open label run-in phase. What was the purpose? Why was this an important part of the trial design?
Well, thanks very much, Michelle. First of all, it's a pleasure to be here with you, and it's a really fantastic opportunity to talk about the study. We designed REALIZE-K to answer two important questions. One was, can we get more people who have heart failure with reduced ejection fraction, have a clear class 1 level of evidence, a recommendation for mineralocorticoid receptor antagonists such as spironolactone, but are not getting it or not getting it at optimal dose because they either have hyperkalemia or are considered to be at high risk. So we wanted to understand, because we've talked about this concept of enablement, MRA enablement in high-risk patients, and how potassium binders can help with that. We have not had a successfully completed clinical trial with sodium zirconium cyclosilicate or SZC to demonstrate whether it actually can enable it when used in a clinical practice the way we would use typically potassium binders in clinical practice, which is in people who actually develop hyperkalemia. So, and then we also wanted to understand the safety of the compound as well. So, as you pointed out, the trial was designed in a very specific way. There was an open label run-in phase where patients that had symptomatic HFrEF and were not receiving spironolactone or eplerenone at the optimal dose or not at all, either because they had prevalent hyperkalemia or considered to be at high risk, were enrolled in open label phase. And there were 2 cohorts within that open label phase. The cohort 1 were patients that had prevalent hyperkalemia, so they had elevated potassium levels at baseline. And those patients were immediately started on SZC, the potassium binder. And once the potassium normalized, they were then initiated or up-titrated on spironolactone to an optimal dose, with the target dose being 50, but the optimal dose was considered to be anything north of 25 milligrams, so 25 milligrams or more. And then in cohort 2, because these patients were not hyperkalemic at baseline, they were initiated after titrated on spironolactone. And even when they became hyperkalemic, they were then started on a potassium binder. So again, same kind of way as we would normally do in clinical practice. We would, start a potassium binder when potassium levels are elevated, or if the patients developed incident hyperkalemia when being up-titrated on GDMT, we would start a potassium binder. So that's how it was designed. And then those patients that achieved optimal dose of spironolactone, 25 milligrams daily or above, and were normokalemic at the end of a run-in phase were then randomized to continuation of SZC or withdrawal to a matching placebo while continuing their then current dose of spironolactone. Now, why was this run-in phase important? For a number of reasons. First is, I think it gives us a pretty good understanding about how many of these patients we can actually get an optimal treatment when using potassium binder as it would be used in clinical practice. It also gives us a better understanding of, what proportion of patients may actually be optimized even without requiring a potassium binder because they never have hyperkalemia. Ultimately, I think its real value is to provide some answers on, how easy or difficult it is to get patients that we otherwise would not even try to optimized both quickly and effectively, but also safely, in a settings that mimics clinical practice. So that's open label phase. And of course, the randomized phase was critically important because that's how you establish the efficacy of treatment as compared with, having a clearly defined control group, which in this case was placebo.
I love that explanation. I love the fact that you, as clinicians, you want a medication that's been worked in a similar style that you would prescribe it to patients. So kudos on this open label run-in phase followed by placebo. Now, speaking about the real world, you did observe more investigator-reported edema events, heart failure hospitalizations, urgent visits in patients receiving SZC. Now, some patients with heart failure may be more susceptible to fluid overload when exposed to it because of increased sodium absorption. So how do you suggest clinicians think about this and balance the potential benefit in SZC in facilitating MRI use with the potential harm of promoting fluid retention?
Well, thanks, Michelle. Important question. And I think, let me just maybe put these findings in a bit of a context first. So as you said, we found your kind of, from very beginning, you mentioned that we found that SZC very effectively improved the proportion of people by a large margin, odds ratio of north of 4. So more than 4 times the likelihood of getting an optimal dose of spironolactone over that 6 months randomized period while maintaining normokalemia and also avoiding rescue treatment for hyperkalemia. So I think, and there were a number of secondary endpoints, time to hyperkalemia was reduced, time to down-titration or discontinuation of spironolactone was reduced. So every efficacy measure that we looked at, except only one of the 5 secondary endpoints, which was change in KCQ, there was no difference in that, but everything else we looked at was in favor of SZC as compared with placebo. The efficacy was very, very clear and clearly established. I would say maybe last comment I will make about the efficacy is even when we use the more conservative definition of normokalemia, not between 3.5 and 5, but 3.5 and 5.5, the results were very consistent. In fact, numerically looked even a little bit better. So even if we're criticized about using too of a lenient definition of hyperkalemia, even if we use a more conservative one, the results are essentially the same or even better for SZC compared with placebo. So I think we have a clear answer on efficacy. You remember me saying that we designed the trial to provide a clear answer, and we got it. Now, on the other hand, when we look at the safety, as you mentioned, we saw more events of heart failure hospitalizations and urgent visits, and we prospectively adjudicated these events using a blinded clinical events committee. So it was done a very rigorous way. And we also very rigorously assessed edema events. In fact, at multiple visits, there was a dedicated case report form where we looked at that. Now, what I will say is that the total number of these events was small. The trial was not an outcome trial and was not designed to provide a definitive answer on outcome events. It was too small of a study for that, about 203 randomized patients. Certainly would require a much larger trial to have a definitive answer on outcomes, on clinical outcomes, clinical events. But that acknowledged there were more of those with SZC than placebo. And the question, of course, is, why? What are the possible explanations for that? And I would say there are several possible explanations. One is whenever you have very small number of events, while they were distributed with more events in the SZC versus placebo group, it's always possible that it's a chance finding. That those can happen. We've seen that before, so we have to acknowledge that. There was a in a relatively modest-sized trial, again about 203 patients. Even when you randomize people, you can get chance imbalances in patient characteristics, and in fact, that happened here, where people in the SZC group were older, they had considerably lower eGFR and considerably higher NT-proBNP. More of them were loop diuretics at baseline, kind of suggesting that they perhaps had somewhat more severe heart failure at baseline just by statistical play of chance, and that might have played into these results. But we also need to acknowledge the possibility, as you pointed out, that because SZC exchanges potassium for hydrogen and sodium, that increased sodium absorption as a result of that might have contributed. And in fact, some additional analysis that we have done, which are in the manuscript, they're post hoc and exploratory, so they have to be taken with a grain of salt, suggest that those people who are more congested at baseline, as indicated by higher NT-proBNP level, that's a group where this imbalance or difference in events was centered, in fact, with SZC versus placebo, which points to this potential sodium absorption in that vulnerable patient population with high level of congestion at baseline as a possibility. So how do we put it all together? I mean, I think the way we put it all together is we say there is, this concept of enablement is a clinical decision-making that we need to make when, as physicians, as doctors, as cardiologists, when we see patients in clinic. And for each individual patient, that decision-making may look a little different, and it should be shared decision-making with the patient. We see a benefit on better GDMT, accomplishing more optimal GDMT and specifically MRA use. But we see a potential for fluid retention types of events, as we mentioned, a few more edema events and also a higher number of adjudicated heart failure events, and people who are more congested may be more susceptible. So I think it's ultimately a balance between these. It's not a very clear answer. There is a potential benefit and there is a potential risk here, and we have to put it all together for individualized decision-making with every patient that we see. The reason we're trained to be clinicians, right, taking care of complex patients, is that we can try to integrate the potential, integrate all of the potential inputs, the potential benefits, the potential safety signals, and make hopefully the right decision for every patient in front of us. And it may not look the same for every patient. The context matters, and kind of patient's clinical scenario and kind of the states that they're in at the time we're evaluating them probably matters as well. One last thing I'll just mention too, Michelle, is that we didn't quite touch on that. Of course, it's in the paper as well. Is aside from MRA use, which of course many of these patients weren't getting MRAs at all or weren't getting optimal MRA dose because of their risk for developing elevated potassium levels, potassium perturbations. Other than that, they were getting really excellent guideline-directed medical therapy. Nearly everybody was on ACE inhibitor, ARB, or ARNI. In fact, 2/3 of patients were on ARNI, more than 70% on SGLT2 inhibitors, which is much better than what we kind of used to seeing even in other trials and certainly in registries. And we normally think of ARNI to some extent and SGLT2 inhibitors as treatments that may actually help with preventing hyperkalemia. And yet, despite that very high use of these agents, we still saw a lot of hyperkalemia in this patient population, which I think should just, is just a reminder to us that I think our perceptions as cardiologists that by using GDMT, we can drive the rates of hyperkalemia down. Maybe there is some of that, but in a high-risk population, we still see plenty of hyperkalemia. So it will continue to be an issue we have to be faced with and figure out how to deal with. Eventually, I think, as as we see more and more advancement in the management of heart failure, we'll hopefully have more and more tools on how to manage it. But as of right now, it continues to be a problem, even on really well done optimal background, SGLT2 inhibitor and ARNI use in this patient population.
It is such a privilege for me and our entire audience to get the take of someone who is such an expert on clinical trials and clinical medicine. And as you know, we always have to fall back on our judgment and our experience when we interpret how a clinical trial may impact patient care. So my last question for you, speaking of that issue, do you think, based on this signal, which might be fluke or might be real, about increasing potential heart failure events in patients who received SZC, should the future include a trial with clinical outcomes to determine if that signal is real?
Well, I think what I can say, Michelle, is that in order for us to know a clear answer on what actually which one of these possibilities that we've discussed is a real answer, or whether it's maybe a mix of those kind of all together, you would need to do a appropriately powered outcome trial to get that answer. Now, whether that will happen or not is a different question. But in order to, I think as clinical trialists, we've learned a long time ago that you design trials predominantly to answer the main question, which is your primary endpoint. That's what they're designed for. That's what they're powered for. And if you want to have a clear answer on outcomes, you have to do an outcome trial. Now, we've had an attempt at that with a different potassium binder called the Diamond trial that was initially designed as a cardiovascular outcome trial. Unfortunately, COVID-19 pandemic intervened, and it was faced with both lower recruitment rates and lower event rates, even more importantly, which ultimately ended up with a protocol amendment and conversion of the trial and more MRA enablement or RASI enablement trial, which is what Diamond ultimately provided the answers for, with patiromer, a different potassium binder. But so there was an attempt at doing that, but unfortunately the timing was not optimal because of COVID-19 pandemic. Will we ever have a trial, appropriately powered outcome trial to provide those answers? We'll have to wait and see.
Well, you heard it here first, everybody. Maybe, fingers crossed, but now at least we have a new tool in our armamentarium to offer best GDMT to our patients. Mikhail, I cannot thank you enough for taking the time to explain the nuances of this important trial to the JACC readership. And don't forget to check out the manuscript and the late breaker at AHA. Thanks so much.
Thanks so much, Michelle. Great to be with you.